Okay, so as discussed on Sunday, the plan is to talk about appendicitis and then gastritis, peptic ulcer disease today. I hope we will have enough time. As always, it's simplified so that we can go through, but you can always stop me, ask questions, and then after lectures, you try and you read further so that you can grasp the concept well. But I hope by the end of the lecture, you should be able to tell me about the etiology and the pathophysiology of appendicitis, and also the clinical presentation of appendicitis, as well as how we would investigate and then manage a case of appendicitis. Okay. So if we all remember our anatomy, we know what the appendix is, or the vermiform appendix. So I'm not going to go into details, but basically, yes, it's a part of the gastrointestinal tract. The role in adulthood as a noun, very much limited. Usually in childhood, it contains a lot of lymphoid tissues, so it helps fight infections. But once you get to adulthood, there's these lymphoid tissues, basically, you tend to lose them. So the role your appendix play in GIT or your immune system, it's not that much serious. And that's why when it's causing problems, or sometimes when you have the opportunity to go into someone's abdomen for a laparotomy, sometimes, we just take out the appendix because we don't want to come back and go to the person's abdomen again later for an appendicectomy. Okay. So the appendix, which is also called the vermiform appendix because it looks like a worm, basically, is a part of the gastrointestinal system. And this part of the gastrointestinal system can get inflamed just like any other part of the gastrointestinal system. Okay, so it's a tubular structure. It has an inner lining, which is called the mucosa, then it has a submucosa, then it has an external aspect, okay? And of course, just like any other part of the body, it also has blood vessels. And this part or these things I've mentioned is quite key because it plays a role in the pathophysiology, and also when you'd have to go in, or once you make a diagnosis of appendicitis and you call the surgeon, you should be mindful of where the vasculature is so that, you don't cause any form of excessive bleeding once you go in to take it out. Okay. So the inflammation of the appendix is an emergency because if you don't intervene, it can progress and move from just a simple inflammation to something else. The appendix could end up rupturing, and once it ruptures, you are in trouble. So it's an emergency, and you'd always have to be on guard. Okay. So in terms of etiology or the causes of appendicitis, we are looking at anything that is capable of causing an obstruction in the appendix. As we move on, you realize that, well, let's touch on that. So classically, there are mainly two types. We have what we call a simple acute appendicitis, and then you have the obstructive acute appendicitis. So we talked about the appendix having a mucosa, which is the inner lining, then it has a submucosa, then a muscularis, and then the serosa, just like any tubular structure in the body. And we are saying that with simple appendicitis, it's just an inflammation of the mucosa and the submucosa. Okay. The thing is that with simple appendicitis, you can sometimes be lucky the inflammation will just resolve and you wouldn't even need surgery. So in terms of management, sometimes you realize that we have patients and then we say, oh, okay, let's start antibiotics and then observe and see. If we don't think this is a classic appendicitis, let's observe and see. And sometimes you are lucky enough, the symptoms would resolve and then you can discharge your patients even without doing a definitive treatment or management for your patient. So simple appendicitis is just inflammation of the mucosa and the submucosa of the appendix. And yes, it can resolve if you don't even do a definitive treatment for it. However, when it resolves, it leaves the appendix with what we call adhesions, okay? And these adhesions would also predispose you to getting another form of inflammation later, okay? Or the adhesions per se can also predispose you to developing the second type of appendicitis, which is the more serious one, what we call the obstructive acute appendicitis. In this type of appendicitis, what is happening is that something obstructs the lumen, okay, or the inner aspect of the appendix. And once the obstruction is done, the appendix is unable to empty its content easily into the gastrointestinal tract close by or the terminal ileum and whatnot. The appendix is unable to empty its contents freely. So you have some sort of pressure building up there in the appendix. And once you have an obstruction and the appendix is unable to empty its contents freely, it acts as a breeding site for bacteria. Okay, and this bacteria would also come in and produce more pus. And once you are producing pus, it even increases the pressure in the appendix further, okay? And this would eventually compromise blood flow because once the pressure in the appendix overcomes the pressure in the appendiceal vein or the vein of the appendix, then you are going to have issues with blood supply. You are going to have some form of stasis, which would eventually lead to blood clot or thrombosis. If you remember our Berkoff's triad that we talked about, you are going to have some form of stasis in the appendiceal vein. It will lead to some form of thrombosis, and this thrombosis is going to lead to some poor supply to the appendix, and eventually the obstruction will lead towards what we call an infarction, or some part of the appendix tends to die, which would eventually lead towards the appendix perforating, okay? And once the appendix perforates, then that debris or the dirty content would be exposed into the whole gastrointestinal system, and then you can develop what we call the peritonitis. Okay, so basically that's it. You have a simple, which is capable of resolving and leaving the appendix with just scar tissues and adhesions, and then you have an obstructive, which will lead to pressure building up in the appendix and eventually a rupture of the appendix, which is a very, very serious medical, or we should say a surgical emergency. Okay. So let's look at the etiology again. So what can cause this obstruction? Commonly in adults, we say feculates can or lead to obstructions more than the other stuff that can cause obstructions. What are feculates? So we are looking at some form of fecal matter, which is very, very hard, incipitated, solid, very, very hard, dislodges from your usual gastrointestinal tract, enters into the appendix. And once it enters, it blocks the appendix because the appendix is a very, very, very narrow tube. So it gets in there, it blocks it, and hence the appendix is unable to release its contents. It basically goes, sits in there, and causes an obstruction in there. Okay, so when you read literature, some of the books will tell you that about 70% of adult appendicitis is caused by feculate obstruction. Okay, then you also have enlarged lymphoid follicles. As I said, in children, they tend to have lymphoid tissues in their appendix. Sometimes this appendix can, this lymphoid tissues can become enlarged, or you can have hyperplasia of the lymphoid tissues. And once you have this, it narrows the tube, and that can predispose you to an obstruction. You could have other things like intestinal worms finding its way into the appendix. This will lead to an obstruction, and then you could have an acute obstructive appendicitis. Also, tumors can develop which can obstruct the appendix. If you've had a surgery before in the past, or even your repeated simple acute appendicitis can lead to fibrous adhesions, as we talked about, and this can lead to obstruction of the appendix. And once the appendix is obstructed, of course, there's going to be a built-up pressure in there, and then eventually you are going to have some sort of perforation. We're saying that the disease is usually uncommon before 2 years and in the aged. Why is this so? Because when you look at the anatomy of children less than 2 years, you look at the anatomy of the appendix, you realize that the lumen or the space in the appendix is very, very, very wide. So it doesn't get obstructed easily. However, as you grow up, this lumen starts to get narrower, and hence it becomes easier to, be occluded by this materials we've mentioned above. When you are getting to 70, then this slight or occlusion would get worse, or we can say that the appendix itself becomes, should we use the word atretic, or the space in there would be occluded totally by natural means. So there's actually no space for it to even get obstructed in the first place once you are becoming aged. Okay, so that is the reason why it's uncommon before 2 years and in the aged. We're saying that before puberty, male and female patients would have a 1:1 disease, in terms of disease occurrence. But once they go beyond puberty, appendix tends to be more common in males than in females. So the course of events, you could have an acute appendicitis, especially the simple one, which can spontaneously resolve, or it resolves, it comes again, it resolves, it comes again. Usually this is what we call simple appendicitis or catarrhal appendicitis. Then you could have the obstructive one, which would lead to a gangrene forming because of poor blood supply to the appendix, and then eventually a perforation and dental peritonitis. Also, you could have the inflammation of the appendix forming, and then this inflammation will catch other nearby structures. So the appendix can get inflamed, and then it catches the immediate viscera or the immediate bowel close to it. That will also get inflamed. Then it catches the greater peritoneum, which also gets inflamed. Then it forms what we call a mass. Okay, so that's what we call an appendix mass. Appendix mass is an inflamed appendix, which has also caught the neighboring viscera and then cuts the greater omentum, comes together, and then it forms some sort of mass. Okay, this mass, when it stays for long, you can start developing an infection in the mass, and then you have a lot of pus forming in the mass. And if you have pus formed in a certain place, packed in a certain place, then we call it what? An abscess. Okay, so you have an abscess developing in the mass. So you could have an acute appendicitis, or the acute appendicitis can develop into an appendix mass or an appendix abscess. Or this acute appendicitis can lead to gangrene of the appendix, a perforation of the appendix, and then general peritonitis. Okay, so that is the cause of event for an inflamed appendix. What are the features? Because even though currently there are high-tech investigative or imaging mechanisms to diagnose whether an appendix is inflamed or not, in medicine or in surgery, we say that the classic way of diagnosing appendicitis is not to using imaging. It is through your clinical skills. So appendicitis is a condition made based on what? Clinical diagnosis. Or we can say that it's a diagnosis made based on what? Your clinical findings of the disease condition. Because sometimes your clinical findings might be pointing to an appendix clearly, but you go and do an ultrasound scan, and then whoever is doing the ultrasound scan, because ultrasound scan can sometimes be dependent on who is doing it, the person will say, oh, I don't think the appendix is inflamed. Or sometimes the annoying part is the sonographers will tell you that you would write a request, and then you'd put right iliac fossa pain, blah, 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 rule out appendicitis. And the sonographer would take the scan and then do all whatever is supposed to do, an abdominopelvic ultrasound scan, and tell you about other organs. The liver is fine, the spleen is this is that. And the main thing you ask the sonographer to do, the sonographer will get to that point and say, however, appendicitis cannot be ruled out. So you take a report like that, and then you are like, but I asked you, that's the reason why I sent the patient to you, but you are telling me appendicitis cannot be ruled out. So diagnosing appendix is based on your clinical skills and the clinical findings. There's a classic presentation of appendicitis. However, this classic presentation doesn't happen for all patients. Research has shown that the classic presentation happens to only about 50% of patients that you meet. So don't expect that every patient you see is going to have a classic presentation, which we'll be talking about now. And so once you don't see that classic presentation, then it means it's not an appendix. No, it only presents in about 50% of cases, as research has shown. So you can have cases coming to you who wouldn't come with a classic presentation, but then you have to be apt and your clinical skills have to be on point to be able to pick up some key features and then make that diagnosis that this is an inflamed appendix. Okay, because if you fail to make the diagnosis, then the appendix will rupture. And if the appendix ruptures, your patient will be open from top to down because there'll be a lot of pus in the abdomen. However, if you are able to diagnose the appendix on time, then all you need to do is you just make a very small incision and then you go and take out the appendix. Okay. So, what is a classic presentation of an appendicitis? So the usual classic history is the patient will come to you and will say, "So Chief, I've been having this pain in my abdomen. Initially, it started," and of course, in medical terms, when we talk about abdomen, I hope you all know we are not talking about lower abdomen in the layman's term. Usually, when the layman tells you my abdomen, they are talking about the pelvic region or the lower abdominal region. When we say abdomen, we are talking about right under the sternum, way down there, okay, where the abdomen can be divided into 9 compartments or 4 compartments, right upper quadrant, left upper quadrant, right lower quadrant, left lower quadrant, okay. So they'll come to you and they'll tell you they have some form of abdominal pain. And this pain started around the umbilicus. So they'll tell you that they had a peri-umbilical pain a couple of days ago. However, now the pain has moved from the peri-umbilical region and they can feel the pain in the right iliac fossa. I believe we all know where the right iliac fossa is. So they'll tell you they have a pain in the peri-umbilical region, which has now migrated to the right iliac fossa. Okay, let me see if I can get a diagram on the internet to make it a little bit more interactive or make the explanations easier. So just bear with me, give me a minute. Okay, can you see my screen now?
Yes, please.
All right, I need my screen with the abdominal compartment.
Yes, sir.
All right, okay, great, okay. So this is what I was trying to describe. So if you look at where my cursor is, the abdomen is basically divided into 9 compartments, okay? So this is it. So you have a right hypochondrium, the gastric region, left hypochondrium, right lumbar or right flank, umbilical region, left lumbar or left flank, right iliac fossa, hypogastrium, and left iliac region. Whenever your patients come to you with any issues with their abdomen, you should be able to split the abdomen into this 9 quadrants in your head and just have a picture of it, okay? So let me see if I can project another one. All right, so you can see this, you can see that the abdomen has been divided into 9 regions. So clearly, if you have this picture in mind, then you know that if a patient should come with pain in the epigastric region, you can see the structures over there. You can find your stomach there. There's a part of the liver there. The patient should come with pain in the right hypochondriac region, then you know that your liver is here and your gallbladder is here, okay? If the patient is coming with issues at the lumbar or the flank, you know that this is where you find your kidneys, all right? When you're looking at the right iliac fossa, you can see that the appendix would be lying somewhere here, okay? So you get the idea. So that's how to split the abdomen and then get things organized in your head so that you can make a good diagnosis based on the abdominal division. So your patient who is coming with classic appendicitis would have pain here, all right? You have pain here. Pain would usually start from here. But the problem is your appendix doesn't lie here. Your appendix is here in the right iliac fossa. So why is this patient giving me a history of pain which started here? Okay. And the problem, the reason is that there's a visceral innervation, okay? And this visceral innervation for the abdomen, basically what's happening is there's a visceral innervation in the midgut, and so situs would usually be a referred pain in the initial phases, okay, when it starts, because that is where the initial pain will be picked up by the visceral innervation or the innervation of the intestinal structures. Okay, so the visceral innervation of the appendix will be picked up first, and you start feeling the pain in the umbilical region. But as it progresses and the inflammation keeps going, then you are going to have the inflammation extend from, as I said, the inner aspect of the appendix, which is the mucosa, all the way out of the appendix. And then the inflammation will spread toward the parietal peritoneum, okay, close to the appendix. And once the inflammation spreads to the parietal peritoneum, then you start feeling the pain at that point where the appendix is, which is the right iliac fossa. So usually your classic history patients will come to you with what we call a migratory abdominal pain, meaning that they'll tell you the pain started from one side, usually a periumbilical pain, and now the pain has moved to my right iliac fossa region. Whenever a patient tells you that, that should quickly take your mind to appendicitis or inflammation of the appendix. Okay, so let's go on. So that's the first part. So there's a periumbilical pain, which later moves to the right iliac fossa. They will tell you they feel nauseous, they don't feel like eating, and they are vomiting. Once a patient tells you these four things, migratory abdominal pain, nausea, vomiting, and anorexia, it's actually pointing you to the direction of appendix. And most of the time, the diagnosis comes out to be an appendicitis. Okay, so that is it. So basically, those are the main general features. Then you can also have other things. Sometimes you can have the patient complaining of diarrhea. Some patients can also complain of constipation. Okay, you as a clinician would now have to examine your patient, and that's where the palpation of the abdomen comes in. So you realize that when you touch the right iliac fossa, which we illustrated briefly in the diagram, once you touch the right iliac fossa, you realize that that part is what? Very, very tender. And then it tells you that, okay, there's a structure here which is inflamed. If you just see a patient who comes to you and says, I have lower abdominal pain, and you go ahead and you just touch the right iliac fossa and it's tender, it doesn't mean that the patient has an inflamed appendix or an appendicitis. It could also mean that another structure in the right iliac fossa is inflamed. Sometimes you could have the ovaries, you could have the fallopian tubes, you could have, there are a lot of structures there which could also get inflamed, right? So that's why it's good to have your differential diagnosis, which we'll be talking about shortly. But most of the time, if you match history with your clinical exam and your history is giving you migratory abdominal pain with nausea, vomiting, anorexia, you touch and you feel that it's very tender, that should point you to some sort of, a diagnosis that, well, it's likely this is an inflamed appendix. Okay. Sometimes when you'd have the appendix perforating and then you have the peritoneum becoming inflamed, what we call peritonitis, then it won't only be tender. If you touch, the patient feels pain, but then when you also take your hands off, the patient feels pain as well, what we call rebound tenderness. So there's tenderness on palpation, and sometimes when you press in deep and take your hands off, the patient would give a sound of pain. That's rebound tenderness. And also sometimes they have what is called guarding. So you are touching, and then whenever you touch, it's like the patient, that particular part that you touch becomes a little bit rigid. We call it guarding. Okay, it tells you that the inflammation has spread from the appendix and it's got into the peritoneum. And once it gets the peritoneum, it can start as a localized peritonitis, but eventually the whole peritoneum of the abdomen becomes inflamed, and then you can have what we call a generalized peritonitis, okay, which is an emergency. Apart from just touching the right iliac fossa for tenderness, there are also some other signs that you can elicit when it comes to appendicitis, okay? So sometimes you can touch the left lower quadrant or the left iliac fossa. When you touch it, but you are touching the left, but the patient is telling you, I feel pain in my right, even though you are touching the left lower quadrant or the left iliac fossa, then they also point you to appendicitis. This is called a rough skin sign, okay, or the rough skin sign. So you are palpating the left, but patient is telling you, I have pain on the right, okay, so rough skin sign. You could also take this patient hip, the right hip, okay, and then you do an external rotation there, an internal rotation. After you flex the hip, you do external, internal rotation. If the patient tells you, I have pain in the right iliac fossa or right lower quadrant, that also points to a possible inflamed appendix, okay, which is lying deep down there in the pelvis. You could also extend and then flex the right hip. Once you do this and the patient tells you, I have pain in the right iliac fossa or right lower quadrants, that also points to an appendix. Sometimes you can ask the patient to cough, and when they cough, they feel pain in the right lower quadrant or right iliac fossa. It's called the Dunphy sign. Okay, so if you're not sure, after you've palpated, you can elicit about 2 of the signs. And then once they are present, it tells you that, okay, yeah, this could be an appendicitis. There's a score system which helps you or sends you closer to your diagnosis, and that is what we call the ALVARADO score or the Mantrel score. Okay, so Mantrel is just an abbreviation of the parameters we look out for. There are 8 parameters, and these parameters are usually given figures of 1, the exception of tenderness, and then leukocytosis, which we give figures of 2. So what we do is once you take the history and you realize the patient gives you something suggestive of a migratory abdominal pain or abdominal pain starting around the umbilicus and moving to the right iliac fossa, then you are going to give the patient a value of 1. Then you ask, have you eaten anything today? Since it started, what have you eaten? Most of the time they'll tell you, oh, I can't eat at all. If you're seeing a patient, so I worked with one senior specialist, general surgeon, very, very good specialist. I mean, once you say there's an appendix, one of the main questions we'll ask you is, what have you eaten today? If you say, oh, I just ate banku, we'll start shaking our head because it's not likely. Usually it's not likely. It's not so classic about it. Of course, you could have a presentation where anorexia is not so marked, but patients come in with some form of pain and just eating, you go and are going to examine this patient for possible surgery, and this patient to be eating banku or kinke in bed. It's not so typical of an appendicitis, okay? But it can happen, but it's not so typical. So anorexia, you also give a value of 1. Nausea, vomiting, give a value of 1. If you touch the right lower quadrant and there's tenderness, you give a value of 2. If there's rebound tenderness, you give a value of 1. If the patient has a fever, you give a value of 1. If the patient has elevated white blood cells, okay, which is leukocytosis, you give a value of 2. If you realize that it's elevated and there are a lot of baby white blood cells being produced, that is what we call a shift of white blood cell count to the left. What is happening is inflammation is going on. So the body is recruiting a lot of white blood cells, because when you have inflammation, you recruit a lot of white blood cells. So the body doesn't have time for white blood cells to get matured before it releases them from the bone marrow into circulation, because we are actively recruiting white blood cells to the site of the inflammation. So when you take your full blood count, you realize that there are a lot of baby neutrophils there, what we call a shift of white blood cell counts to the left. Okay, you give a value of 1. So afterwards, you add your values. If your score is less than 5, then we usually say that an ALVARADO score of less than 5 or a Mantrel or less than 5 is not so likely. It could be, but it's not likely. Okay, you would rather want to keep an eye on this patient for a while. A score of 5 or 6, possibly. A score of 6 or 7 can say likely. A score of 8 to about 10, we say highly likely that this is an appendicitis. Let's go in and take the appendix out. Okay, so that's your Mantrel score for you. So once you're getting Mantrel score of about 6 to 10, it means that, okay, likely there's an appendicitis. So let's just prepare, and then we can go in. What investigations can you do for your patient? Of course, we are saying that it's a condition of clinical diagnosis, so history examination. However, even as part of your Mantrel score, you realize we're talking about WBC and all that, so you need a full blood count. Okay, these are all supportive investigations, not really diagnostic, but supportive. You can do inflammatory markers, C-reactive protein, ESR, usually they will be elevated. Sometimes you need to be sure, so you have to rule out other things. Like a UTI can give you signs that looks like appendicitis, okay, or symptoms that look like appendicitis, because UTIs can make you vomit, can make you nauseous, you can have abdominal pain. So you do a urine RE to rule that out. Also, you could see a patient, and this is one important thing. Whenever you see a female patient who has right iliac fossa pain, the first thing you should be thinking about is a possible ectopic pregnancy, even before you are thinking about an appendicitis, because the ectopic will kill the patient faster. because if the ectopic ruptures, you are going to have hemoperitoneum and it will kill the patient faster. It wouldn't give you time to come and start antibiotics. Whereas if an appendix ruptures, you can start antibiotics and all that. If an ectopic ruptures and a patient is bleeding, you are in trouble. So when you see a patient, a female patient, right iliac fossa pain, always do a pregnancy test first to ascertain if the patient is pregnant or not. Ectopic pregnancy, your ONG lecturer will take you through the other investigations that you do, beta HCG, serial beta HCG, ultrasound scan and whatnot, but always rule out an ectopic gestation when you're seeing a patient with signs which you suspect to be an appendicitis. You can also do an ultrasound scan, and usually when you do an ultrasound scan, you see something we call a target sign. At this point, let me try and pause the share and see if I can get you a target sign of the internet. Okay. Okay, so if you can see my screen here showing an ultrasound scan, let me know. Can you see it?
No. No, sir. No, sir, we can't see it.
All right, okay, just a minute. Can you see it?
Yes, please.
Yeah.
Yes.
All right, great. Okay.
Sir.
Okay. Great. So you can see, just follow the cursor. So this is an ultrasound scan that has been done, and then you can see the sign. You know, if they say a target, usually when people go for shooting and
Doc, please, your voice is down.
all right, I think my microphone, it does that sometimes. So let's just give it some time.
I think it's getting better now.
Yes, great. So when you go for shooting practices and target practices, you know, you can see those sometimes black and white rings or red and white rings. You can just follow this. You can see the cursor. So this is a target. Okay. So when you do a scan for a patient and is inflamed, usually you see what we call a target sign over there. Okay. So this is a target sign. The target sign, you have a center which is hypoechoic. Okay, they say hypoechoic in ultrasound. You do that in imaging. It means that it's black. Okay, and then hyperechoic means it's what? White. Okay, so you can see a dark center, white ring, called a target sign. All right, good. Okay, so we go back to our screen. So you do an ultrasound, you see a target sign. You can also do a CT scan for the patient. If you are so not sure, a CT scan will also rule out other things. Yes, please.
Target as in TARGET.
Yes, please.
Target.
Yes, targets.
Okay. Okay.
Yeah.
So when there is darkening, what does that suggest? Is it an inflammation of the appendix?
Exactly. Yes. So it's telling you that the appendix is inflamed. Okay.
Okay.
All right. So you can also have a CT scan done And the CT scan will also diagnose other things. Maybe you are not so sure, you do a CT and you go and find some tumor sitting at that right iliac fossa or something. So sometimes if you are not so sure, especially in the case of an appendix mass, which we talked about, which is an inflammation of the appendix and it has caught the neighboring viscera and then the greater omentum together to form a mass. Sometimes you're not so sure if this is an appendix mass. You go ahead and you do a scan just to be sure you're not dealing with a tumor, a malignancy, a cecal tumor or something sitting there. Okay, so that's it. What are your differential diagnoses? Of course, remember when we did enteric fever, we said that you could have inflammation there and in the terminal ileum, that side. Okay, so typhoid ileal perforation could be a differential diagnosis. So we are thinking this is an appendicitis because of vomiting, fever, and all that. Typhoid ileal perforation too can give you vomiting, fever, and pain at the right iliac fossa. Okay. Then a ruptured ectopic gestation, as we've already talked about. You could have an ovarian cyst becoming twisted, and this would also give you pain at the right iliac fossa if it's the right ovary involved. You could have an intestinal obstruction as a differential diagnosis. Sometimes you could think, okay, this could be a perforated peptic ulcer disease, also as a differential diagnosis. Not so classic because of the sites, the right iliac fossa, but it's good to entertain all that, especially if the appendix comes to you late and there's generalized peritonitis. Wherever you touch down is painful. So you are not sure if it's the appendix, especially if the patient is unable to really give you any proper history. Wherever you touch is tender. You are not sure if it's a perforated peptic ulcer, maybe the stomach has perforated or the duodenum has perforated, or it's a perforated appendix. Okay, so with this, you have to open the patient from up to down and inspect all the organs and be sure of exactly what is inflamed and has perforated. Okay. Diverticulitis or outpouching. Yes, please.
Please, is the torsion of the ovarian cyst is the same as the corpus?
Two different things. So if they say torsion, torsion means torsion. The English word for torsion is twisting. If we say torsion, it means that something is twisted. So you could have an ovarian cyst, and this cyst can twist around itself. And when it twists around itself, it compromises the blood flow to the ovary. You get it. So then it becomes very, very, very painful because there's poor blood supply there. It's also an emergency because you need to go in and relieve so that there will be enough blood supply. So that's torsion, okay, or twisting of the ovarian cyst. A corpus luteum cyst, however, is different. So a corpus luteum would form usually after ovulation and all that. The whatever is left there in the ovary would undergo changes, forms a corpus luteum, corpus albicans, and then it would regress. Sometimes you can form a cyst in the corpus luteum, especially it's common in pregnancy where you have the corpus luteum, which is the remnant of the structure that released the ovum. It can form a cyst, and sometimes this cyst can become a bit painful, what we call corpus luteum cyst. Okay, so there are two different things.
Okay.
Are you okay? Yeah. So you could have, yes, you could have an inflammation in an outpouching of the bowel, what we call diverticulitis. You could have a Crohn's disease, which is a type of inflammatory bowel disease. Okay, inflammatory bowel disease, there are two types. There's Crohn's disease and there's ulcerative colitis. Ulcerative colitis is just restricted to the inner aspect or the mucosa, whereas Crohn's disease it goes all the way from the inner aspect to the outside of the intestines. Okay. Then there's in children, they could have what we call mesenteric adenitis. Okay, so like some lymph nodes in the mesentery can get inflamed and you might mistake that for an appendicitis. You go and open and you realize the appendix is fine. As we said, appendix is not so common in children. So you go and you realize it's a mesenteric adenitis. Okay, then you could also have stone. So severe pain will push you to go and open up. You go and the appendix is fine. And later you realize it was just a stone in the ureter, which eventually was going to be passed. Okay, so you would have just opened the patient up basically for nothing. And then malaria, DKA, which is diabetic ketoacidosis, all of this can give you pain in the lower abdomen or generalized abdominal pain, and sometimes you can mistake it for an inflamed appendix. Okay, so these are your differential diagnoses. What are the complications? So we've talked about generalized peritonitis, which happens when the appendix becomes inflamed and there's poor blood supply, and eventually there's a rupture of the appendix and it releases its contents into the whole abdomen, thereby leading to an inflammation of the peritoneum. You could also have an appendix mass forming, which I've been talking about, and this mass can develop an abscess inside there. So you have an appendix abscess. You can have an abscess developing in the pelvic region. Sometimes someone has an appendicitis, you go in to operate and you realize that there are pockets of pus collections in the pelvic region, under the liver, under the diaphragm. So whenever you open a patient up and you're thinking that possibly it has ruptured, you have to look under the liver, under the diaphragm, in the pelvic space for pus, so that you can wash everything out. Because if you don't and you close up, you end up having to come inside again, because you would have done the appendicectomy or removed the appendix all right, but the presence of pus will still be causing a spike in patient temperature. Patients won't feel better unless you drain the abscess. That's the only way you drain an abscess. You treat an abscess, you have to get it out. You need to drain it. Antibiotic administration alone is not enough. You need to drain the abscess. Also, depending on where the appendix, the obstruction is, it can actually affect the terminal ileum, and that can cause an obstruction of the intestines. Also, an appendix which perforates can lead to generalized peritonitis, which can cause some form of what we call paralytic ileus. Also, excessive vomiting and all that can lead to loss of electrolytes, can lead to shock, and this will lead to functional intestinal obstruction. Remember, you need potassium and whatnot for contraction and all that. If you vomit a lot, you have hypokalemia, you can develop an intestinal obstruction, not because there's something mechanical obstructing the intestines, but because you've lost a lot of electrolytes, so the intestines is unable to contract. And we call this one functional intestinal obstruction. Then, of course, you can develop sepsis as well. How do we manage? So management is dependent on what we have in front of you, okay? We have conservative management and then we have definitive management. Mind you, the real form of management for appendicitis is taking the appendix out. That's like the definitive management. However, sometimes if you are not sure, you are allowed to do a conservative management, and that is not the main thing. That's not the main form of the treatment. That is, we call it, you are observing to see what will happen. Okay, so whilst you are doing that, your patient is taking IV fluids, you are giving antibiotics to your patient, you are monitoring a whole lot of things, you are monitoring vitals, you are checking the patient's urine output because you want to make sure the patient is not going into shock. You've made sure your patient is not eating, because if the observation doesn't work, you need to go in and then operate the patient. So you keep nail pairs, you pass an NG tube to just decompress the stomach, okay? So that in case you need to go in and perform your surgery, your patients won't have a Mendelssohn syndrome or aspirate for the food that is in the abdomen to get, the food that is in the stomach to get into the lungs. So you pass an NG tube to drain the stomach, okay? Then you put your patient on antibiotics. Usually we do something that would cover gram negatives and anaerobes, okay? Because that Those are the common organisms we find in the GI tract. So in our setting, most of the time we do Cipro and then Flagyl. Okay, so we do Cipro about 400 milligrams 12 hourly, Flagyl about 500 milligrams 8 hourly, whilst we are managing the patient. Some people also do something which is broader. They can decide to do Rocephin and then Flagyl. Okay, where the Rocephin is giving some broad spectrum cover, but the main focus is to hit the gram negatives, okay, because that is what you find in the GI tract, and your Flagyl is hitting the anaerobes. Okay, so you do this for your patients, you control the temperature. Remember, IV flow, it's very, very, very important because your patient might go into shock, your patient is having temperature, your patient would sweat, what we call insensible fluid losses. So you need to replace. So whilst your patient's on admission, you're giving the daily requirement, which is about 3 liters, okay, to your patient. And then where we're saying, okay, you are giving about 1 liter of Ringer's lactate and then about 2 liters of 5% dextrose to your patient, okay, or daily requirements, or sometimes DNS to your patient. But then you also need to replace the deficit. So if you think your patient has lost about 1 liter through vomiting, you need to replace that 1 liter in addition to your daily requirements. If you think your patient has lost 2 liters, you need to replace the 2 liters. And we usually replace with crystalloid. So either normal saline or Ringer's lactate. Okay, Ringer's lactate is the physiological solution because it contains, the things that fit well for the body's physiology. So usually in cases like that, you want to replace with Ringer's lactate. And you request your lab. If something like a BEM finding comes and then potassium level is low because of the vomiting, then it means you need to institute some potassium treatment so that your patient doesn't get hypokalemic. Because once your patient develops hypokalemia, it's not appendicitis you are dealing with alone. You are actually going to deal with a paralytic ileus or a functional intestinal obstruction, which I've talked about. So you would have taken the appendix out, all right, but you realize that it's been days and your patient is still not pooping, basically not there, and it's because your patient is hypokalemic. So whenever we do surgery for patients, especially that prior to that your patient has been vomiting and all that, you need to keep a close eye on your electrolytes, okay, because you could have done a perfect surgery, but because you fail to keep a close eye on your electrolytes, it will lead to an electrolyte imbalance and you are going to have a paralytic ileus or a functional intestinal obstruction. Okay. So once you go in, appendix is inflamed. Once you open and you go in, whether appendix is inflamed or not, if you got your diagnosis wrong and you went to open and you go and then it's a perforated typhoid ileum or typhoid ileal perforation, you have to repair the perforation and take the appendix out. You don't just repair the perforation and say, well, the appendix is fine, so I'll take it out. You come back later with appendicitis and you need to take that one out. So once we open you up, they will take the appendix out because they don't want the situation whereby they open you out and say, oh, appendix is fine, let's close up and go. No, they'll take the appendix out. As I said, in adults, it doesn't play much of a role. Okay. And then if it's an abscess, you would want to drain the abscess. If it's an appendix mass, you are not in a hurry to go and open to take out the appendix. Why? Because if you go in, it's not only the appendix that you are going to find. You're going to find the appendix in a ball with some part of the GI viscera and then some parts of the peritoneum. If you go and take that mass out, it means you've taken some parts of the intestines out. So you worry the patient. So if it's a mass, you need to manage conservatively with antibiotics and be doing daily measuring of the mass just to be sure the mass is resolving. And once the mass resolves, you come back later and then perform what we call an interval appendicectomy for the patient. Okay, you come back later and then take out the appendix when the mass goes down. But once there's a mass, means that there's inflammation, there's edema. If you open, you don't see anything, you end up taking out the wrong structure. So you manage for this to subside. Then you come back and then you take it out. Okay. So even though I said it was going to be brief, it's a bit detailed. You try and read through the slides, you should be able to know the types and the pathophysiology. You should also be able to know how it would present, okay? And then you should also be able to do some supportive investigations. Don't forget to do your full blood count, and you should know how you are managing. Before we switch to the next topic, I'll take about 2 or 3 questions if there are any. Then I will stop this. Okay, well, Nick, you're the one recording, so you can keep recording. But what I usually do is, because the size tends to be very long, if you're having a 2-hour, I tend to stop the recording after each topic so that that can be converted and then we have another one. But I mean, it's up to you how you want to do it. So I'll take questions and then we'll quickly move on to the next topic. So any questions, please?
All right, Doc.
Okay. Are we okay?
Sir, whether
Yes. Yes, please.
If the condition is like appendix mass, as I said,
Yeah.
when you open up and it's mass, you close before you come back later, or how do you manage it? How do you do it?
If it's a mass,
You
know.
Close the incision, then you come back later and come and operate on the appendix.
Okay. If it's a mass, you would even know, so you won't go in. If it's a mass, the place won't only be tender. It would form like a mass, like a ball over there. So you won't even go and open in the first place. You understand?
Oh, okay.
You won't go and open. So if it's there and you are not sure if this is a tumor or a mass, then that's where you request for your CT scan. Your CT will tell you, oh, it's just the appendix which is inflamed and has cut the closed intestines and then the omentum. So then you won't even go and open in the first place. Okay.
Okay.
All right.
All right.
All right. So I think we can take the next topic. Yes.
Yeah, Doc, I want to find out, what about if you open and you discover that the omentum and the mesenchyma, and you remove it, because I know they supply the GIT with blood, that's the nutrients.
Yeah.
So if they remove it, what happened to the supply to the GIT?
Okay. So it's a good question, but when you take a look at your anatomy atlas and you open the GIT supply, you see that there are lots of connections, what we call anastomosis, okay? So it's not just one blood vessel going to supply just one part. It has a lot of branches. You understand? So you are allowed to do, if you go in and maybe an omentum is affected, maybe there's peritonitis, so you go and open and then the omentum looks inflamed, so you want to do an omentectomy or cut the omentum off. You don't need to worry about blood supply to the other aspects. There are diverse branches there, so it would supply the other things nicely. Okay.
Okay. Thank you.
Welcome. So your lecturer for surgery will touch on it more into details if this is not detailed enough. But this, I touched on it because even though we are doing internal medicine, we are also doing emergency medicine. And once you are the ER, you'll be seeing a lot of appendix where you would have to assess and call the surgeon to come and take a look. Okay. So this is more of an emergency medicine. And then the surgeon comes to take a look and goes to perform the appendectomy or appendicectomy. Okay. So we move on to the next topic.